Thanks, everyone. So I am fascinated by anatomy and captivated by anatomical variants and accessory muscles. So much so that I now get a greater kick out of identifying an anatomical variant and an accessory muscle than I do in finding the cause for the patient's presentation. And that's probably not something you want to admit to a room full of colleagues, but I'm convinced that someone else knew this, and that someone told Danny Macklin, so she knew if she asked me to speak on anatomical variants, I wouldn't say no. And here I am. I've been asked to speak specifically about muscular anatomical variants, and in doing so, it's really difficult not to touch on some of the neural variants that we encounter, such as a bifid median nerve, or a C5 piercing variant responsible for a number of thoracic outlet symptoms. It's difficult not to touch on some of the vascular variants that we encounter, such as a persistent median artery or a bovine aorta, as depicted in Leonardo da Vinci's 1507 masterpiece drawing of a woman's torso. The left common carotid shares its origin with the brachiocephalic artery. It's difficult also not to touch on some of the bony variants that we encounter, such as an avian spur or an os intermetatarsium, or the os vesalianum pedis, a rare accessory ossicule at the base of the fifth metatarsal, more likely to be the cause of base of fifth pain than the insertion of peroneus brevis. It's also difficult in an anatomy discussion not to touch on eponyms. Now, eponyms are, of course, a person after whom a structure or entity is named, and they're everywhere in the anatomical sciences. I've already mentioned the os vesalianum pedis. This was named after Andreas Vesalius, who's considered to be the father of modern anatomy. He was the first to challenge Galen and 1,200 years of anatomical knowledge that had been accepted as the gospel. The only exciting thing about having to scan a Dupuytren's contracture is the personal story behind Guillaume Dupuytren, a man who was absolutely despised by his contemporaries, including his student, Jacques Frank, who described him as the brigand of the Hotel Dieu, which is the hospital in which they worked and trained. And as it turns out, Dupuytren wasn't the first to publish on palmar contractures of the hand. Astley Cooper did that 10 years prior, meaning that Dupuytren's disease should actually be called Cooper's disease. And you're probably wondering if there's an eponymous muscle variant that we scan. And the answer is yes, there are a couple of them. But my favourite, without doubt, is the pyramidalis, or the fallopian muscle. The same fallopio behind the fallopian tube, the fallopian canal, and the fallopian ligament. The same fallopio who conceived of the idea of the condom. Now, the pyramidalis originates on the pubic symphysis and inserts into the linea alba. And it varies in size and symmetry. Sometimes it's completely absent, other times it's absent on one side only. Hence, it's considered vestigial or a variant. An accessory muscle implies an additional muscle to that seen in the status quo. Now, the pyramidalis can be used as a landmark in caesarean sections. It can be used in muscle flap reconstructions, and it's implicated in adductor longus tears through the relatively new anatomical concept of the plaque complex. And from an evolutionary point of view, or phylogenetically, the pyramidalis is related to the anterior pouch you see in a kangaroo and an echidna. And if that's not the most fascinating thing you hear all day, I'll eat my hat. Now, one thing that everyone here will at one point consider is, why do I need to know about anatomical variants in accessory muscles? Most of the time, they're a completely incidental finding and they have no bearing on the clinical question at hand. And that's true, often they are, but there are many other occasions in which anatomical variants can be mistaken for pathology, or an accessory muscle is the palpable lump in question, or the cause of the patient's compressive neuropathy. And there are plenty of occasions in which anatomical variants and accessory muscles will dictate the surgical approach when it comes to tendon transfers and reconstructions. And knowing this and recognising this is what separates the good sonographers. And if that's not cause enough, then at a minimum, we should be able to describe and label what we see on our screens. If we can't, then what is there that differentiates us from radiographers? Nothing. Now here is an example of an anatomical variant that's often mistaken as pathology. This is the long head of the biceps at the bicipital groove in the shoulder. I've seen this described as a bifid biceps. I've seen it described as a longitudinal split tear of the biceps. And obviously that diagnosis could lead to unnecessary intervention, be it injections or even a tenodesis. But this is a normal anatomical variant. This is the aponeurotic expansion of supraspinatus, a tendon-like structure that comes off supra and inserts into pec major, as denoted in yellow. And this is an image from Moser that shows the normal long head of the biceps tendon, and this is the aponeurotic expansion of supraspinatus. Moving down the arm, occasionally we'll run into the anconeus epitrochlearis and the accessory abductor digiti minimi muscle. The former forms the roof of the retroepicondylar groove, the latter the roof of Guyon's canal, and both are unequivocally one-star accessory muscles, more likely to induce a yawn than a raised eyebrow. Now, the literature suggests that these are potential sources of compression and entrapment to the ulnar nerve, but I tend to find to the contrary. I think they offer a layer of protection to the ulnar nerve. The exception is probably when you have posterior elbow joint osteoarthritis and an anconeus epitrochlearis. Then you can be predisposed to undersurface irritation of the ulnar nerve. Now let's look at a 5-star accessory muscle. And this is an example of an accessory muscle that will present as a palpable lump. We're looking at the dorsum of the hand, and given its location, the referrer will read query ganglion or query carpal boss. But unlike a ganglion and unlike a carpal boss, this lump will feel soft, it will feel mobile, it will feel fleshy. Normally, the muscle bellies of the extensors should not extend to the carpal bones. If they do, such as in this case, we have an accessory muscle. We have the extensor digitorum brevis manus. And this is the same on the foot. The only muscle on the dorsum of the foot is extensor digitorum brevis. So if we see a muscle on the dorsum of the hand, overlying or superficial to the carpal bones, we have an accessory muscle, extensor digitorum brevis. Manus is simply Latin for hand. And in this same location, it may not be common knowledge that there are 2 extensor tendons that run along the second metacarpal to the index finger, extensor digitorum 2 and extensor indicis. An extensor indicis is a really commonly harvested tendon for transfers and reconstructions. And in 5 out of 6 patients, it is located ulnar and deep to ED2 when you're scanning the dorsum of the hand. But in every 6th patient, that's not the case. It will, however, always maintain the most distal muscle belly of the extensors. And this is how plastic surgeons ensure that they harvest the correct tendon. They'll make an excision in the dorsum of the wrist, tug on the most distal muscle belly, and that will reveal extensor indicis. If we look at the volar wrist now, and here's another 5-star accessory muscle. Normally, there should sit nothing between FPL, FCR, and the volar distal radius. But occasionally, we can have this, which is not to be mistaken for pathology. This is not a ganglion, this is not fluid. Healthy muscle is black, which is why trochanteric bursitis is often called when it's just the glute med muscle belly. This is the flexor carpi radialis brevis vel profundus. And no, it's not the longest named muscle in the body. The Ganser muscle is an interesting one. The Ganser muscle is an accessory muscle belly of FPL or sometimes FDP, and it's present in 44 to 60% of the population, so it should be considered a variant. To identify the Ganser muscle, I just find the muscle belly of FPL and get the patient to wriggle their thumb. As we scan more proximally, we'll fall off the main muscle belly of FPL, and if present, the Ganser muscle is a really small accessory muscle belly more proximally in the forearm adjacent to the median nerve. The literature suggests that we should consider the Ganser muscle in cases of median nerve and AIN issues. It potentially has a role to play with some rehab physicians with their spasticity management. Here's a really nice pro-section that shows main muscle belly of FPL, and this is the tiny accessory muscle belly, which is the Ganser muscle belly. The Palmaris longus is probably the most well-known anatomical variant in the body. It is absent in around 15% of the population, and it is commonly harvested for tendon transfers and reconstructions. Its removal results in no functional deficit, hence it's commonly harvested. And this is without question the coolest variant of this variant that I've ever encountered. This was a young male who presented with carpal tunnel symptoms, and he had a mass over the volar aspect of his wrist. It didn't feel like a ganglion, it felt soft, and it looked muscular, and that wasn't present on the contralateral side. This is a reversed Palmaris longus, in which the muscle belly is distal and the tendon is proximal. And this is a really nice pro-section as well that shows reverse Palmaris longus. So the muscle belly is inserting into the transverse carpal ligament, and the tendon of Palmaris longus is located proximally. Really cool. Now, I always wondered as a junior sonographer, if we have a Palmaris longus, does that mean we also have a Palmaris brevis? And the answer is yes, for 97% of the population. The Palmaris brevis is located at the hook of the hamate and the ulnar nerve bifurcation. And what's cool about Palmaris brevis is it inserts into the skin. Remember at uni always being taught that muscles and tendons insert into bone. Well, here's a case of a muscle inserting into the skin. And here is a multi-slip APL tendon. That's a normal and common finding. And what's cool in this case is we have a slip of APL that inserts into the abductor pollicis brevis muscle. How cool is that? Now, the lower leg homologue of the Palmaris longus is the plantaris, a vestigial muscle, vestigial tendon steeped in history, controversy, and confusion. You see, ever since the calf strain was first described in the 1880s, the plantaris has been attributed as its primary etiology. And even today, I see worksheets written, reports published, threads tweeted, and Instagram reels posted that continue to suggest that this is the result of a plantaris rupture. But how can such a small and diminutive tendon, a tendon by definition is avascular, produce such a disproportionately large hematoma? And the answer is it can't, and it doesn't. This always was and always will be a medial gastroc tear. If the plantaris is present, and if the plantaris is to become abnormal or torn, it will occur here at the level of the distal Achilles and almost always look like this. Now, being able to identify the plantaris muscle belly is important, particularly in cases of popliteal artery entrapment syndrome. We want to be able to identify the muscle so that we can guide our Botox injection into the plantaris muscle belly to treat this condition. In the tarsal tunnel, our main occupants are Tom, Dick and a nervous Harry, tib post, FDL, tibial nerve and FHL. And on occasion, we can have a guest within that tunnel, a flexor digitorum accessoris longus. So this is the most common accessory muscle you'll see in the tarsal tunnel. It has a variable origin, and in this case, it inserts directly into the quadratus plantae muscle. And note, it's very close and intimate relationship with the tibial nerve. This is the FDAL, that's the tibial nerve. So this was a case in which a gentleman presented with exertional neuropathy of his foot. After 1 or 2 Ks running, his entire foot went numb, and it was postulated that that was due to the presence of an FDAL. And this is another case. So it was a young male who presented Query-Morton's neuroma. There was no neuroma and there was no bursitis, so such a finding prompts you to look at the tarsal tunnel where we saw a FDAL. Now, laterally, we are frequently asked to interrogate the perineals for cases of tears, split tears, tenosynovitis, instability, subluxation, and pain. But we perhaps don't always attribute those symptoms and conditions to the presence of an accessory muscle or tendon. Here we can see peroneus longus and brevis, and here we've got a little accessory tendon. This is the peroneus quartus, a muscle that is infrequently or inconsistently described, named and classified in the literature. Confusion abounds. In this case, it originates from peroneus brevis and comes down to insert directly onto the calcaneus. This is the peroneus quartus. Now, if we continue on with, there's peroneus quartus there, and there's an image from RadSource. If we continue on with peroneus brevis, occasionally we'll see a tiny slip of tendon come off peroneus brevis and go down to insert onto the proximal phalanx of the little toe. This is the peroneus digiti minimi quinti tendon, an accessory tendon that aids in the extension of the little toe. It has been harvested and used in different tendon reconstructions previously. And this is a really nice pro-section that shows a dual insertion of the PDMQ. While we're on this image, does anyone know what this tendon is? Yeah, this is peroneus tertius. So this is a normal bit of anatomy that's inconsistently present, but it's often confused with peroneus quartus. So if we look at the EDL component, the most lateral tendon will not go down to the little toe. It will insert somewhere in the midfoot, and this is peroneus tertius. And the reason that's important to know is when we have an intratendinous ganglion of peroneus tertius, we can diagnose it as an intratendinous ganglion of peroneus tertius. We are, after all, in the business of science. If science isn't accurate, it's nothing. Now, there are a couple of accessory muscles that remain unticked on my bingo card. One of those is the sternalis, an accessory muscle that sits superficial to pec major. Pec major is the coolest muscle in the body, and it runs parallel with the sternum. It's often confused as pathology on memos and in CTs. I've seen quite a few of these on CTs, but I'm yet to get a nice ultrasound image of the sternalis. And the other one I'd love to get is the tensor fascia suralis, or get this for a name, the ischio-aponeuroticus, a muscle that originates from the hamstring and goes down onto the calf. Could you imagine the look on the radiologist's face that reads your worksheet that says note is made of an ischio-aponeuroticus? That would be fantastic. So, anatomical variants and accessory muscles are an undeniable and crucial part of MSK ultrasound.
Anatomical variants are a crucial part of all disciplines of ultrasound. And at first they seem very overwhelming and intimidating. But if we understand normal, we can then recognize variations of normal and then differentiate this from abnormalities and pathologies.